At Boise State Public Radio, you can listen to all of our podcasts free of charge. We don't lock any episodes. We don't require subscriptions, nothing like that. But the truth is, although our podcasts are free to listen to, they're not cheap to make. A lot of time and resources go into bringing you the daily news on The Connector, statewide voices on Idaho Matters, and the long-form journalism in podcasts like Scandalized, Extremely American, and Mustang. That's why we're asking, if you can, please consider supporting Boise State Public Radio podcasts today. We have a lot of work planned for 2025. Yes, new podcasts, but none of it would be possible without the generous support of our listeners. Every gift matters, whether it's $5 or $50, whatever feels right to you. Head to our website, boisestatepublicradio.org, and click that blue donate button. If you're giving to support podcasts like the one you just hit play on, leave us a comment with your donation and let us know. Your support will help make sure these podcasts keep coming and remain free and accessible to everyone. Thanks so much for listening.
There are certainly other issues. We tend to see tuberculosis, especially in populations that are homeless, that are congregated into small areas, including prisons. We see it with alcohol and drug abuse. We can see it in a lot of different settings. There is also some growing resistance to some of the drugs used to treat tuberculosis in parts of the world. And there is some concern that perhaps even the COVID pandemic itself could have reactivated some tuberculosis that was latent, and especially in patients that got very ill and had to get treated with steroids. But that we just don't know. So it is unusual, but unfortunately, it does still happen in the United States.
So, Dr. Pate, Central District Health and the school are getting in touch, of course, with the parents of kids who may have come in contact with that student who was diagnosed with TB. So I have some questions for you. How contagious is this? And then my other question is, what kind of signs or symptoms would you look for? Because I have to say, I don't know if I would even know what to look for.
Right. So it is contagious by people coughing or can even, depending on, we're not told what the state of the tuberculosis disease was in this student. Or we weren't even told it was a student. Maybe it was a faculty or staff person. I don't know. But tuberculosis can be in a latent phase, which you would have no symptoms. And we a lot of times do the skin test to see if people have been infected and have that latent disease, in which case it's not causing any harm. It could reactivate later. But that's one. Another is that you've got active tuberculosis because you've just been recently infected. And those people will typically have cough. They'll have fevers. They may very well be coughing up phlegm. They can have sweats and so a number of those kinds of symptoms. The worst case would be if somebody has what we call cavitary disease, where there's like a hole in the lung where the tuberculosis is eating through. Those are the people that are the most contagious. Assuming this is somebody who wasn't particularly had bad disease, because apparently it went unnoticed for a period of time, months, probably not very contagious. It is contagious. We don't know who might have gotten it. It's not like COVID or measles. Mm-hmm. It's not that contagious, but it can be in the air there. And so it is possible when you have large gatherings of students, as you would in a school, that quite a number of people could have potentially been exposed. Even if you're exposed, not everybody's going to get infected. So it's very hard to know without testing if somebody's been exposed.
And my understanding, Dr. Pate, is that we don't typically give a tuberculosis vaccine here in the United States when children go in for their childhood vaccines, correct? Because we don't see a lot of cases of TB anymore.
That's correct. So there is a vaccine for TB. It's called BCG, and it is used in many parts of the world because there are high levels of tuberculosis. We don't give it in the United States because, first of all, mostly it serves to just prevent people from getting the severe disease, which we rarely see in the United States. It doesn't necessarily prevent infection, and it does wane with age. And it also will give false positive tests to that skin test where you get the TB skin test, meaning that you might not have ever been exposed to TB, but you get the skin test and it's positive. We always ask if somehow people got the BCG vaccine, but we don't use it in the United States. We don't have enough cases to justify it, and it kind of gets in the way when you have low incidence like the United States does.
So, Dr. Pay, CDH is also advising that only people who get contacted by the department should actually get a test for tuberculosis. That might be a little bit hard advice for a parent to follow, right? When you find out that there's been this case at your school, your first reaction for a lot of parents would be, well, I want to get my kid tested. Can you talk about maybe why they would make that decision? But also, you mentioned that sometimes those tests could have a false positive. Is that correct?
Well, that would be for people that got BCG vaccine, which I would not expect that hardly anybody, if anybody at that school had received it, unless they're foreign students. But I think, there's this delicate, it's an important balance, but it's a frustrating one that public health authorities don't want to give out enough information that people can figure out who this person is. And that's a very laudable objective. On the other hand, not giving us more information makes it hard for parents, like you just said, that might be worried. And it makes it harder without more information for those of us that are advising people to be able to say, yeah, that's the exact reasonable approach here, because I don't know what was the state of that person that was infected, what kind of exposures that person might have had. If it's somebody that worked in a back office at the school and wasn't interacting with students, there's going to be very limited exposure. If it was a popular student and they changed classrooms all the time, and the person was on a sports team or cheerleader or something like that, that's going to be a lot of exposure. So it's just really hard for us without a little bit more information. I wish we could get more information so that we could help reinforce those messages and give confidence to people. I do think there's wonderful people that work at CDH, and when Central District Health gives a statement like this, I do tend to think it's been well thought out and well researched. So I believe that's the case. It'd be easier to say these and help reinforce these messages if we had more information.
Well, I do really appreciate the fact that they want to keep anonymity, right? I mean, I think that's really important. With that said, I can guarantee you that kids at Meridian High School know who it is because kids talk. And that was the case, right? That was the case at both my kids' school when it came to whooping cough. Kids know. Not to say that the health departments, they need to keep that anonymity, but kids talk.
It's not going to take Sherlock Holmes to figure this one out because, whoever that person is going to be conspicuously absent from school for a while they get started on their treatment and all. And so, we still have to do everything we can to protect privacy and make sure that, that people aren't fearful of coming forward with things that are important for the health of the other students. But on the other hand, we don't want information that will tell us who the person is, but we would like more information that would tell us about the medical circumstances so that we can also assess the risk for ourselves.
Dr. Pate, you've been tracking an unusual illness that is particularly dangerous for children. It's being called Disease X, and it is really unfortunately taking the lives of folks in the Democratic Republic of the Congo. Can you tell us what we know so far about this disease?
Yes, this got my attention a while back because This is a remote area of the Congo. I think it's about 400 miles away from the capital. It's hard to get to. The roads aren't great. And right now they're having their rainy season, so it's even more difficult to get there. But there were reports that starting back around October, at the end of October, that a large number of people were getting sick, typically fever, headache, cough, shortness of breath. And of course, there's a lot of things that could be.
Mm.
But then what we heard when we most recently got this reported was that more than half the cases were occurring in children, especially less than 5 years old. And that was one of the areas of highest deaths from this, which is really obviously concerning in of itself. And so a lot of speculation about what this might be. Of course, common things being common, COVID, influenza, those kinds of things. But what caught my eye as someone who deals with trying to diagnose difficult things was there was a report by the health minister that in the really severe cases, they noticed profound anemia, so much so that some of these people that were dying, if they had access to healthcare, we would have been transfusing them. That's very unusual. That is not something we commonly see with flu, influenza, the other kinds of common things. And so that piqued my interest. Then, and especially thinking of something that would cause that kind of anemia, but also predominantly affect these very young children. Then we got health investigators dispatched to the area. They did some rapid tests and they found that a high number of them, I think it was 10 of 12, were positive for malaria. And obviously, malaria can cause anemia, and so that could be satisfying in that regard. But even when there's different strains of malaria, but even when you look at the most severe strain of malaria, usually the mortality it increases as people get older. So this was still kind of opposite of what I would have expected. It is difficult to say because the other thing about this area is all of these people are generally high rates of malnutrition, and of course that can make them more vulnerable and have worse outcomes to almost any disease. So I don't think we can say for sure, but my guess is that malaria won't be the explanation. I think that it's more likely that there's something else going on in addition to the malaria that's causing this, and we're waiting for those tests. People are calling it disease X. I think that's first of all premature and unfortunately they call it disease X because we don't know what we're dealing with. But disease X is really meant to be a disease that develops into a pandemic or has that pandemic potential that is new, and so we don't have a name for it. We don't know that this is what this is at all. It may turn out to be something common we just still haven't thought about or hadn't shown up on testing. So it's a little premature, but it is concerning.
Well, and especially with this anemia, Dr. Pate, can you explain for folks who might not be familiar what anemia is and really how dangerous, it can be? Because, it's one of those things too where it can creep up on you and you may not even realize that you are anemic. And I'm just talking, for folks living here in the U.S.
Right. So anemia is a low red blood cell count. And so we were talking about earlier that it's frustrating we can't get more information from public health authorities about things. For me as a physician, what would be hugely helpful is if the health ministry in the Congo could give us information about that anemia, what degree of anemia, because many people in Africa have anemia. There's high levels of sickle cell anemia, other things that might predispose. And if they're malnourished, most everybody that's malnourished is going to have anemia. But what got my attention is when the health minister is saying it's so low that they would have transfuse people if they had that capability. Now we're talking about, this is not a run-of-the-mill anemia. This is not the degree of anemia that you would expect from iron deficiency, from not having enough folate or B12 or those kinds of things in the diet. This suggests something is happening with this infection is causing it. And infections can cause anemia a number of different ways. Sometimes a bacteria or a virus can trigger an immune reaction against the red blood cells that destroys them. And so you can, and if we're given enough information about what those tests showed, we can kind of tell if that's what the problem is. Sometimes more severe kinds of infections, particularly viruses, can get in the bone marrow and impair the cells that actually make your red blood cells. And so there's a number of different mechanisms by which you can get anemia, but that can also clue us into what might be causing this. For most people in the United States, of course, iron deficiency is very common in females that are still menstruating, and your doctor likely is checking for that if you have particularly heavy or frequent menstrual periods. We do see other anemias from time to time, and we always have to check to make sure whether that's something that is fairly innocent or whether that could reflect a more severe underlying disease. So it always is a good idea to have that checked by a doctor.
So I want to switch to another health issue that we're seeing. Now, this is being called the bleeding eye virus, but it's actually known as the Marburg virus. So, Dr. Pate, what do we know about this? I mean, other than the really disturbing name it has.
Yeah, they've gone for the dramatic, obviously, and with Marburg virus, which is one of the hemorrhagic viral fevers, kind of like people probably have more likely heard about Ebola, things like that. There's a number of viruses that can do this. The thing about Marburg is that in some settings, it has among the highest mortality rate of any virus that we see, approaching 80% of people getting infected dying. It's hard to know what the real mortality rate of that is because a lot of these, well, in fact, all of the outbreaks except for the very initial one have occurred in Africa where there's not a great access to healthcare. Almost any of these infectious diseases, if you have better access to healthcare, you're going to have a lower mortality rate. So we don't know what that is, but it's high. And what Marburg is a virus that is transmitted by bats. And so people can get this disease when they have contact with animals that might have been infected through the bats, or it can happen through human spread when you have contact with a person that's infected, their blood or bodily fluids. And anyway, these illnesses typically begin with fever, chills, headache, muscle aching that's intense. Some people get a rash, so they can have chest pain, sore throat. Nausea, vomiting, and diarrhea can also be a sign for some of these hemorrhagic viruses. But what happens is over the next 5 days or so, it will typically increase in severity, and then people can develop shock. They can become confused. Then this bleeding, which can happen from almost any orifice that you have, but it can also happen in the eyes, not in everybody. And then it can cause, usually when people die, it's because it has caused multiple organs to shut down. And we see the deaths around 8 or 9 days after they get sick.
So, Dr. Pate, the CDC as well as the State Department have actually issued a travel alert for parts of Rwanda because of the Marburg virus. So are they doing that because they are concerned that this disease is spreading, or is it to keep it from spreading?
It's the latter. In fact, I would tell you in modern recent history, Rwanda, of all places, is probably the prime example of a masterful handling of this outbreak. We have a lot to learn from Rwanda. They did a fantastic job. This outbreak started in September. They now have it contained. What we do to declare an outbreak of this virus over is we take double the longest usual incubation period. So incubation period for this virus can be up to 3 weeks. So what we do is we double it. And so we say 42 days from the time of the last person recovering from this. And then what we do is once they're recovered, once they go for 2 negative tests, 48 hours apart, and then 42 days after that, then the outbreak can be declared over. And we're close to getting there. They have done a masterful job. This outbreak, in my mind, is fully contained and under control. We're just waiting for that final period to make sure nobody else shows up with infection. But they have, I wish the United States could do as well as Rwanda does in managing an outbreak like this. It's really impressive.
Okay, Dr. Pate, we wanted to talk about something a little less disturbing than disease X and the Marburg virus. So there's a new study out, and it's by Harvard. So just to be clear, Harvard researchers did this study, and it says that eating dark chocolate can reduce your risk of getting type 2 diabetes by 21%. Okay, Dr. Pate, will you break down this study for us? Because I have to say, this just seems too good to be true. Or am I not reading it? Because now, I'm sure folks are going to think I can eat an entire candy bar. I'm assuming maybe that's not the case.
Well, I too am glad to talk about something that is going to be well-received news and doesn't involve bleeding from your eyes. So this study, and there's been some prior studies that have suggested that there may be health benefits to dark chocolate. This was a large study, and what they determined through their study was that if you consumed 5 or more servings per week of chocolate, that it showed a significant, about 10% lower risk for developing type 2 diabetes. And they were comparing that to persons who rarely or never ate chocolate, which I have no idea where they found those people. But what they found, to the point you made, that is if that it is dark chocolate and higher quality dark chocolate, that risk reduction could be as high as 21%. Actually, using statistics, it could be anywhere from 5 to 34% reduction, but 21% is the estimated benefit. Now, here's the catcher. Number one is that it may not be that effective for older people. So after 50 or so, you might not get the same benefits, but it does benefit younger people more clearly in this study. And not every study that's been done has shown this benefit, so we do need more research, but we've got more than one study that does tend to support this. There is also another study, I think it was in Japan, where it tended to benefit men, but not women. So that's a kind of an outlier, of course, yes. But in general, the dark chocolate was found to have overall health benefit and didn't contribute to weight gain statistically in this group. Whereas if you ate milk chocolate, it did definitely correlate with weight gain and certainly did not seem to have a significant impact on lowering diabetes. So good news, dark chocolate, bad news, milk chocolate.
In fact, Dr. Pate, one of the authors of this study said that not all chocolate is created equal. And what I find interesting about this is actually just the other night, I had a little piece of dark chocolate and my kids were like, why do you like that? Like, that's so gross. And I'm one of those people, I don't really like sweets and I do not like milk chocolate. And so I finally said to them, I go, you know what it is? It's really bitter. And I like that bitterness. So is it because there's something in dark chocolate that's not in milk chocolate?
Well, that would be the natural, logical assumption. We don't know what it is. We have ideas. So first of all, the critical difference between milk chocolate and dark chocolate is that dark chocolate has at least 45% cocoa. And you can find widely varying percentages of cocoa even in various dark chocolate products. And they'll usually tell you on the wrapper what that percentage is. And what we don't know from this study is having a 70% cocoa dark chocolate bar or something better than a 50%. We don't know the answer to that. The other thing that is a leading, and let me say another difference is milk chocolate has milk in it, and dairy tends to be inflammatory to the body. So that could be that it's just the difference between whether you have dairy in it or not, which the dark doesn't. The other issue is that milk chocolate typically has a lot of sugar and dark chocolate doesn't. But one of the things that is suspected is that there are chemicals called polyphenols, and there's a couple in particular in that class that it appears they may have a function in reducing insulin resistance. In other words, when insulin is released from your pancreas to deal with the sugar and bring that sugar that you eat and then absorb those levels down, it will decrease the resistance of insulin to cells, making it more effective for you to clear that sugar. There's also some evidence to suggest that those polyphenols also protect the insulin-producing cells of the pancreas from oxidative stress, and there's also some evidence to suggest it might decrease inflammatory cytokines. You remember we talked about with the MIS-C with COVID, where the children got extremely sick, that a lot of times that's from cytokines, and those are a measure of inflammation, so it decreases that. So there's a number of theories, but the answer is we don't know why the dark chocolate would apparently have this benefit versus not the milk chocolate.
So I have just under 4 minutes left with you, Dr. Payton. I really want to quickly talk about this new poll out from Gallup that said that 62% of people say health insurance is the responsibility of the government. I'm just curious, does that number surprise you?
Yes and no. The surprise is related to the fact that that number over time has widely varied. Right now it's at a relative high. And I'm a little surprised because a lot of the political rhetoric that we just dealt with in the election is whether we should get rid of the Affordable Care Act and so forth. So, yes, I was surprised, and in part, no, I was not surprised. I can only guess at why, and I think that what is happening is people are realizing that healthcare, and of course, we've known this for a long time, is too expensive. Medications are too expensive, and that even with health insurance, be it deductibles, co-pays, et cetera, or things that just simply the insurance companies aren't covering, that people are feeling like it is just too expensive, and that we need a government program. And of course, this is one of the arguments of those that suggest we should have like Medicare for all and all, that maybe a government program would give us better coverage and reduce our out-of-pocket spending. That's my guess. I'm not sure. There's just a lot of frustrations with healthcare, and I share many of those.
Well, as always, Dr. Pate, we so appreciate you taking time every Wednesday to talk with us and giving us the facts and the science when we are talking about medicine and healthcare. We've been talking with Dr. David Pate. He is the former CEO of St. Luke's Health System. He's also the co-author of the book, Preparing for the Next Global Outbreak. Dr. Pate, thanks so much for joining us today.
Thank you, Gemma.
And that'll do it for this episode of Idaho Matters. Thanks so much for listening. And just a reminder, you can find all of our episodes wherever you get your podcasts.
If you like podcasts like this, explore more from the Boise State Public Radio podcast family. There you'll find a mix of daily news, Idaho Voices, and in-depth series on a wide range of topics. I'm talking wild horses, political scandals, sustainable ranching, and militia groups in a post-January 6th world. Wherever you get your podcasts, just search Boise State Public Radio to find what Idaho's NPR station has in store for you.